outcomes in the same unit. So basically it makes it manageable. So, just for example, here we have, somebody might say you have a dialysis might be 0.8 quality, and life hypertension might be 0.9 quality. Now we'll talk about some of the critiques of this a little bit later as we go forward. So what are some of the properties of an ICER? So an ICER is a ratio. So you guys probably remember from grade school. It can grow larger if the numerator grows larger. That was cost. So if the cost between one drug and another drug is big, the ratio gets bigger. Just so you know, big ratio means bad, okay? So or the denominator may shrink. So there might be a small effect in difference, okay? So typically the worst ratios, largest occur when you have a more expensive intervention providing little or no health benefit. So somebody comes out with a brand new antihistamine that they're going to charge 10 times as much as the current one, but it actually makes no particular difference in terms of how much benefit they get. That would give you a bad cost-effectiveness ratio. Okay. Some misconceptions and critiques of cost-effectiveness. So cost-effectiveness always means saving money. Well, that's not true. Okay. Cost-effectiveness is a way of informing decision-making. Okay. So it is not about saving money. It is about telling you how well you are spending your money. It always implies choosing the least expensive therapy. Again, that's not true. So, for instance, a ICD costs tens of thousands of dollars, as a one-off shot, whereas giving the drugs for treating, let's say, heart failure might be cheaper. But when you look at the cost per benefit, actually, ICDs tend to have much more cost-effective. Okay, so an intervention affects a lot of people. Well, again, not always true. Again, it all depends. This is because the ratios are a little tricky here. So, so banning asbestos, probably affects some people. Choosing seatbelts on the bus probably affects even more people. So. Even though the banning asbestos might be more cost-effective than putting seatbelts on a school bus. An intervention by itself is very effective. Yep, got a question?
Can we ask a question?
Yeah, absolutely.
You just made a marvelous value judgment by saying that an increased ratio is always bad.
No, I didn't. I said it's worse. And bad is a judgment. Yeah. Okay, so. Well, so that's a good question. So the cost, so the value judgment here is, am I using my money to the best effect for the best good for people? That is true. That is true. But if I'm making a choice for others, then in terms of this tension between the individual and society, then I might not make the same judgment. If I am choosing to, if I'm choosing to, let's say, if I'm going to spend money on 10,000 vaccines for children, which I know are going to result in them living 10 extra years of life, versus spending the equivalent amount of money on one person for their therapy, that's a tough choice. And that, and so that one person might actually think that that is more valuable to them, but on the other hand, society might think something very different. We'll go into that a little more in detail as we go forward, but it's a good question. So just to go on to that, so when you're making these choices, you are having to make a choice between different kinds of things. And just to go along those lines, sometimes you make a choice about things that are not, even though you might think they're valuable, we don't actually follow through on, even though they might be cost effective. So for instance, spending some money on making sure that pregnant women don't smoke. Okay, we know that's highly cost effective and highly desirable. Do we as a society spend money on that? Not so much. Okay. So again, cost effectiveness analysis really doesn't say, give a moral judgment. It says how well you're actually, it informs your decision. So this is really about, cost effectiveness analysis is about transparency. So just to go on about another misconception in terms of CEA reduces innovation. Well, there is actually no evidence about that. So in fact, it probably in some cases, improves innovation in that it tends to say that Me Too drugs or Me Too interventions are not worth the investment and probably should drive investment into developing new modalities as opposed to using the same modality. And then again, is CEA rationing? Again, I've already talked about this. CEA really is not about rationing. It's about informing your decision making. But that being said, rationing does exist, and we certainly have mechanisms for rationing right now, and those that are probably most in the news right now are price and purchaser characteristics. We've all probably been aware of the news in California about the individual insurance market, where people were driven out based on the cost of their plan or based on pre-existing conditions. So rationing does exist, though CA is not the mechanism for that. So some of them were critiques, and I'm defining these as critiques, and these are things that are ongoing debate and evolution in the world of decision analysis and cost effectiveness analysis, are things like cost calculations. Where do you start counting costs? Do you start at the factory? Do you start at how much you paid your wholesale supplier, your retail supplier? Where do those costs come from? Qualities, for example, have this utilitarian origin, which some people can argue with. And where do these, and where you're valuing that quality of life that you just mentioned? Is it a transient quality of life, or is it a long-term quality of life? Is it fair to really aggregate a whole bunch of people's outcomes into one pool for analysis, or do you really need to consider everybody individually? That's a big philosophical debate. Can a single measure capture an individual's quality of life? Okay, does that point 8 really make it? Does that really capture what we're really interested in? Well, there's a big debate about this in the field, and so there's certainly a movement called the multi-attribute model, where you're actually looking at different domains in health and quality of life to kind of have a more nuanced approach to quality. And then there's the big debate in public policy whether or not these qualities actually potentially value disabled individuals less. And this is a question because we ask people in the public, how much would you value spending a year in a wheelchair? And somebody in a wheelchair might answer something very different. Okay, so that's a big debate. Now, that in some sense is a question of anticipated quality of life versus actually experienced quality of life. But again, that's a problem that people are working on and trying to solve. And then there's a question, does this potentially insert financial constraints into the doctor-patient relationship? Again, that's very arguable, but it is something that people have been wrestling with. So some of the common ethical issues raised by CE and CEA. So ethics of ignorance. I would say this: what you don't know can hurt you. Okay. So and I see this is particularly true in the clinical realm. So if ignorance is lacking knowledge, education, or awareness, how does that actually impact on my clinical care? So I would say most definitely it affects the clinical contract. So as a clinician, every clinician probably knows, every doctor-patient encounter involves medical decision-making and ideally shared decision-making. And in this clinical contract, as a clinician, we're trying to provide it's assumed in this contract, we're trying to provide the best recommendations and therapy to the best of their knowledge, of our knowledge. And on the patient side of the contract, basically, you come to see a doctor, in a sense, you're saying, you're trying to agree or adhere to the recommendations within the limits of your understanding or autonomy. Okay, you're part of this contract. It's a relationship. It's not somebody just dictating to you. So what are the implications of this? So no treatment as a clinician is without risks. And I have to tell you, and I don't want to disturb too many people who are not clinicians here, the Institute of Medicine has published a recent document saying about 85% of the things that we actually do in medicine have really no evidence, right? Really no good, strong evidence, okay? So, it is what it is. And it takes a lot of effort and time to generate evidence, so to be fair. And people are working with the best intent in mind. And again, without evidence, providers are potentially exposing patients to real harm without any real evidence of benefit. So I would say, from an ethical perspective, that obligates every clinician in this room to struggle to improve their understanding about what they're doing and why they're doing and the differences between different therapies every day. Now, because this is a contract, it's not just by yourself. So as a patient, it's a lot easier to be selfish or to make choices based on, on your own benefit when you're unaware of any harms resulting in your choices to others. This is sort of that effect alone world. So it raises the question, how much responsibility do you have a patient to become aware of the consequences of your choices on others and on yourself? When you come in as a patient and you demand a test, which you're demanding resources to be used, how much responsibility do you have to know the consequences of that? Now, we are moving from a society of being totally paternalistic, where you have no responsibility, to one where you have more acknowledged autonomy. I'm not going to say how much that should be, but it's clearly something that is a big question of debate. So ignorance in clinical care basically means not knowing what choices are available and the consequences of those choices. So, yeah.
Can I ask you to use the microphone?
All right, gives me a chance to take a sip of water.
I have a question about the individuality of the quality of life issue.
Mm-hmm.
And that is, when a clinician identifies for a patient what's the risk and what's the proper direction in which to take your treatment, and a patient wants to recognize the fact that the value of being totally unresponsive, say, to any kind of sensory input in the future. This is an extreme case, of course. But it may be very different from the reaction of a different person to such a situation. And somehow or another, that ought to be part of the issue that guides the clinician in his interaction with a particular patient, the fact that some patients have different values for aspects of life than other patients, and that doesn't seem to have a formal entry into this process.
Okay. Yeah. Well, so if I understand the question, so the question here, to rephrase, is in understanding and developing this kind of approach to understanding your decisions, how much does individual variability count, right? Okay. So I would say absolutely does it count. I mean, again, it depends on the level of your decision making. You know, if you're making a decision based in the clinical contract there in the room, that is an individualized decision, and the value in any good clinical contract takes into account the values that the patient brings to the table. Now, I'll give you, for example. So when I was my first fellowship at Tufts, when I was first learning clinical decision analysis, we actually had a clinical decision analysis consult service, where we actually took these tools and we actually went individually to patients and applied the whole gamut of tools, asked them very specifically what their own personal values were for the decision. So this is really about a method. It's not really about a policy, you know, at this point, though that certainly these tools can be applied at different levels. They can be applied at the individual level, where it helps you and your doctor understand more clearly about the consequences of your choice. Now, you're absolutely right. People value the choices differently, just like somebody mentioned earlier that they might value walking over some other treatment. Okay, so again, that is how it's not. This is really not a question about imposing a choice. It's a question of eliciting and making explicit how you value the outcomes of the choice. Just like I mentioned that first slide about the structure of a decision. You have to choose between different things, but you have to actually pay very close attention to actually what is involved in the steps leading to that outcome, and actually how you value that outcome. Without valuing the outcome, you don't have a choice. And that choice, as you said, is valued differently from person to person. Now, again, I want to raise something that's probably a little disappointing to some folks out there, is that most science, and one of the big challenges to most clinicians in the field, is how do you take information that you learned reading a trial that was done in some large study with a bunch of people, and how do you apply that from that population to that individual in front of you? Because really, they're not necessarily the same. So we have to apply a lot of different tools and intuition to actually bring the knowledge from the general to the specific, and from the specific to the general. So what I'm talking about here in terms of cost, decision analysis or cost effectiveness analysis is really a way of actually making your desires and your preferences more explicit and more transparent. And this is something that is a big struggle. Transparency is a big struggle. And we'll go through that in a little bit further. I'm going to keep moving, but hopefully we'll have time for more questions as we go forward. So I just want to point out some of the ethical consequences of not knowing is when you don't know things, you actually lose choices between real options. And that, from an ethical perspective, is reducing autonomy, right? If I take away your knowledge, I'm basically taking away your options. Right? So in addition, if you don't know what you're doing, you can unintentionally or intentionally spend your effort on things that are wasteful, which again takes away things from somebody else. So being uninformed can violate do no harm, among other things. So again, this is the point we were just making. So the work of all these people doing this, of comparative and cost effectiveness, is really to seek to inform end users of the details of their choices. Make it transparent. Make the consequence of the choices explicit and reduce ignorance. And again, when you're making shared decision making, there's responsibility in both parts. So again, what these techniques are trying to do is to help inform your decision-making process and make that shared decision-making better and clearer. Because you really don't want, I think most people have a high value for transparency. Most people really don't want decisions made without their knowledge. At least that's the presumption, okay? So this is a quote from one of my old bosses, one of my first mentors. So the problem with CEA is that it makes everything explicit. The benefit of CEA, it makes everything explicit. Okay? So CEA is fundamentally about transparency. Now, again, I said, well, I think everybody wants transparency. Well, that's not necessarily true, unfortunately, if you look at history. So transparency is something that is an ideal that we strive for. At least we think we strive for. But if you look at politics, many times people actually, there are vested interests that don't necessarily want you knowing all the details. All right? Or, to be perfectly frank, sometimes some of those details are frightening at the individual level. And what do you do? What do people do when they're frightened of a hard choice? So hard choices are hard, and they're called hard choices for a reason. But anyway, so I think being transparent is a core feature of why we do this sort of stuff. So policy making. So this is another big issue in terms of cost effectiveness, and again about this whole new institute, whatever it's going to end up being called. So this is about policy making and ethics is about transparency, and hopefully transparency sets the stage for fairness. So what is policy making? Well, policy making is developing goals and actions, procedures to reach or manage those goals. Okay? So democratic societies find it difficult to reach consensus concerning the principles for healthcare distribution in the face of resource constraints. As I suggest here, I don't think we need a reference for this. Yep, question back there.
I don't want to take time, but I think there's a fundamental ambivalence about the notion of autonomy in America. In any other country, is autonomy in relationship. The Jewish culture is autonomy in relationship. And I think unless we confront the myth of autonomy by and of itself, we're simply, running after our own tails. Again, I don't want you to comment on right now, but I'm interested in how that comes through in your lecture.
Well, I think that's an excellent point. I think there are beliefs that we have about ourselves, and this is sort of the question about that early slide about the tension between what we should do and what we actually do. And I think we should save that a little bit more towards the end, but I think that's a very valid point. So when we're making policy, there's a whole school out there that's developed called procedural justice. So this concerns fairness and transparency of the process in which decisions are made. And this is based on, at least the current version of this is based on work by Daniels and Sabin, and on the idea of the accountability reasonableness. And basically it has 4 elements to it: publicity, relevance, revision and appeal, and enforcement. Okay? And enforcement really is not the police, it's really making sure that publicity, which is making sure all the elements of a decision or a question about how you allocate something are out there for public, for everybody in this room to know about. Relevance means that basically what we're talking about is relevant. Okay, it's not we're not talking about something doing with fruit flies. We're talking about people. Okay, and this is something that that we really have a choice to make something about. It's a real choice. And revision and appeal are basically that once a process has been put in place where you've actually looked and analyzed the decision, that people in the public and around in the society have a chance to go back and say, wait a second, you missed something. Or wait a second, I don't agree with that. And go back and revise it. And enforcement basically says there has to be a mechanism in place that those processes come about, that they are publicized, that they are made relevant, and that there is mandated opportunity for revision and appeal. So, and as we mentioned, fairness and transparency are issues that people feel very strongly about. And to, again, this question of autonomy, but fairness and transparency, there's a lot of experimental economics, a lot of experimental psychology that really says that people really care about fairness in transactions. And also people are willing to sacrifice if it's felt to be fair. So in this context, CEA, cost comparative effectiveness and cost effectiveness primarily help fulfill the aim of relevance. By making choices and the consequences of those choices explicit, by making sure that these decisions are based on reproducible evidence, making sure it's arguably transparent, though clearly it's more technical than some, that it's subject to revision and appeal. Again, when you put out, as some of my colleagues in the audience will say, you publish a model out there or about a decision, well, you got peer review, you got people, everybody can see it and actually can tear it down if they want to. And it's also based on a framework that's relevant to fairly meeting the healthcare needs under reasonable resource constraints. Again, we can argue about how much utilitarianism and how much cost effectiveness that is there as part of that, but that's certainly something that many people feel is at least a starting point for a reasonable debate. So who practices this policy approach? Well, most of the rest of the civilized world except for us. Okay. So the most famous or most well-known institute is National Institute for Cost Effectiveness Analysis, though Germany, Canada, Australia, Israel, Netherlands, and several others also use this explicitly by making, again, what is this? These are organizations that are set up based on this procedural justice idea, that we have to allocate our resources, and we want to make sure that it's transparent, it's public, and subject to revision and appeal. Okay. Now there are reasons why, again, I think related to some issues about transparency in politics, why we have had problems with that in this country. And we'll see, hopefully we'll see, and we can talk about that afterwards, but hopefully we'll have some chance to talk, hopefully see what our new institute will yield and whether or not it gets taken down like the previous ones. So, ethics of resource allocation. So this is something you probably all thought when you first came in here. This is what I would be talking about, as opposed to everything else I've been talking about. So, so here we're going to get a little, get a little background here. So some kind of attitude towards resource allocation. So there's a bunch of literature out there saying, basically, people want, when you ask them, the best available care regardless of cost. And people also think that healthcare is too expensive and we should reduce costs. They also think that healthcare should be available for everyone. Can we achieve all these goals? I don't know. There's some people that argue, like Uwe Reinhardt, that says our healthcare, our budget is going to continue to expand ad infinitum, and we should continue to spend as much money as we want. Other people would disagree with that. So, should we try to strike a balance? So, these are fairly well established from public surveys. So, a little market design 101. I don't want to make your eyes glaze over, but I need to discuss a little bit about what is allocation and how do we actually do it. So all allocations systems are types of markets. So all markets have explicit and implicit rules. So an explicit rule might be in a stock market, the opening bell and the closing bell. Okay, things have to be open and closed. That's an explicit rule. A implicit rule might be in a stock market would be things like market makers, people who have kind of gained certain prestige and roles that are kind of informal that allow them to actually guide some of the market. Markets also differ based on what, jargon alert, jargon, agent symmetry, okay? What that means is how many buyers and sellers are there? So in a stock market, you might have thousands of buyers and thousands of sellers, but if let's say I'm the government and I want to decide what airplane I'm going to use for my tanker, I have to choose between Airbus or Boeing, okay? So there's a different number of purchasers and buyers. There's also a question of frequency of transactions. So again, stock market, you're making these transactions all the time. Let's say I'm buying a house. I might do that once or twice, maybe 3 times in my life, okay? Or maybe for those clinicians in the room, the National Residency Matching Program is a type of market, okay? But again, that's a market that has a buy and sell one time during the year. And then there's a question of private versus public knowledge. So when somebody's buying somebody's fruit, let's say in this picture, if you see it every day, everybody knows how good the fruit is, they can see it. But if I'm buying CDOs or other derivative instruments, I might not know so much about what's in that. And that there's a certain different levels of buying. Or if you bought a house, clearly your house inspector probably didn't catch all the things that went wrong, later on in life. So different markets require different rules to achieve their goals and to be sustainable. So that's Market Design 101. And so when we design our markets and how we allocate things, these are all different rules that we have to think about. And our ethics and how we decide our priorities really influence what are the right set of rules to put in. It doesn't mean that's not free trade or that we're not doing a lot of transactioning. It just means that you need to have rules to make markets successful. So balancing versus optimization. So most current biomedical ethical debates implicitly wrestle with the resource allocation issue. But I would say the real debate is not economics versus ethics. It's rather between different conceptions of social justice and different ways of reconciling the individual versus the collective good and welfare. So this is a question of resource balancing and resource optimizing. So for optimization, for those of you who are not a geek like I am, optimization is an engineering term, which basically means to paraphrase, getting the most out of what you have. So if I was going to classify our 2 ethical standpoints that we wrestle with all the time in healthcare, on the balancing side is egalitarianism, and you might say its goal is really all individuals should be equal or are equal, and optimizing where utilitarian, which usually has a basis in utilitarianism, which basically strives for the greatest good for the greatest number. Now on the egalitarian side, you have to question what is equality of what? Okay. Is it equality of opportunity? Is it equality of purchasing? Is it equality of power? Is it equality of access? Again, that's something for debate. On the optimization side, really the question about what you value is the morality of an action is based on the general outcome. So in the end, from an allocation issue, the balancing side is really how do we minimize loss to any person? Okay, any one person. How do we make sure nobody really loses out? And on the optimization side, really how do we maximize benefits across all society? And not necessarily being sure that everybody actually gets exactly the same thing, but society as a whole is better off. So these are just some interesting slides I came across, which I think are kind of fun, and how our perception of balancing and rationing particularly has changed over time. This was at World War II. So World War II, we thought actually rationing was a good idea. Okay? Everybody gets a fair share, and maybe we're moving towards a future where optimization is more valued, where this is, I don't know, anybody like Star Trek here, but I do, and so Spock's saying here, the needs of the many outweigh the needs of the few as he sacrifices his own personal good for the greater good of his peers. Believe me, finding pictures to emblemize these ideas was a challenge. So let's talk about some of the things have played out in practice. So one of the more famous things that have gone on here in debate between optimization and balancing, and I'm fully free, afterwards you can disagree with at any particular point. I'm